I appreciate all the dignitaries, members here present, ladies and gentlemen. I am going to discuss with you the work that I have been doing in the last 4 years. And this work has been about barriers to early diagnosis and treatment of cervical cancer in Uganda. And I have concentrated on issues regarding awareness, perceptions, and the pathway to treatment. And that is really going to be the outline of my presentation, which we are going to discuss. Ladies and gentlemen, there is no any meaningful journey that starts without a purpose, and that purpose must have a motivation. I was motivated to get onto this study because in the process of my clinical practice and with review of clinical and research data available, majority of cervical cancer patients are seen quite very late. Cervical cancer is the most common cancer in Uganda among women, and for every woman who dies with cervical cancer leaves perhaps not less than 5 orphans. And all of us, particularly those of us who may have been orphaned, understand how bad it is to be an orphan. And so there is nothing less remaining other than to join hands and be in solidarity and find out a reason as to why patients with cervical cancer come late. And that has been the main question that has guided this study through and through. What are the factors that contribute to advanced stage cervical cancer at diagnosis? And now I am going to take us through briefly through the background of cervical cancer and cancer in general in Uganda, and then the model which we have used in this study. The incidence of cervical cancer is a lot higher in the low and middle income countries, Uganda one of them, as compared to the developed countries. And in East Africa, the incidence is up to 42.7 women per every 100,000 women. And this is compared to as low as 5.5 per 100,000 women in Australia. And we are saying in Uganda the incidence is increasing. In the last 20 years, the incidence of cervical cancer has increased by about twice. And there are perhaps several factors that may be contributing to that, and we will look at some of them. Now, it's not just the incidence. The burden is also in terms of mortality and the cost that is spent in managing cervical cancer. Death from cervical cancer is quite high in East Africa. 27.6% per 100,000 women who get cervical cancer actually die of cervical cancer and related conditions, as compared to just 2 women per 100,000 in Western Europe who develop similar condition. So mortality is really a big problem in this particular part of the world. And indeed, 87% of all the 266,000 women, deaths that occurred in 2012 from cervical cancer did occur in the low and middle income countries. Now, the reasons for the poor survival in the low and middle income countries are poorly understood, but may be related to some of these barriers. And these barriers include limited awareness on cervical cancer symptoms and signs, misattributions of symptoms of cervical cancer to other illnesses, poor access to health services, and perhaps healthcare professionals' incompetence or the feeling that they are unable to do adequate diagnosis of cervical cancer and manage it appropriately. Now, the problem in this particular aspect is really regarding knowledge and how to use this knowledge. So the knowledge gap that has existed that I identified is a limitation in the data on community awareness of risk factors, symptoms, and the management modalities for cervical cancer in Uganda. If we had this data, we really could be able to develop interventions to promote uptake of risk reduction strategies and promote prompt symptoms recognition and health seeking. Secondly, there's limited data on the psychocognitive processes that occurs within a person who develops symptoms that might be or that are of cervical cancer. And this influences the health seeking process. If we have information about these processes, what goes on within the person, we definitely can be able to develop interventions in the public health perspective that can help early health seeking. The third problem is incomplete understanding of the barriers to health seeking and advanced stage at diagnosis. If we understood the nature of the barriers then we can be able to develop interventions that would improve access to quality biomedical care for cervical cancer. I therefore set out to assess perceptions, beliefs, and awareness about cervical cancer, the help-seeking process, and barriers to health-seeking in order to inform appropriate interventions. And these interventions include promoting prompt help-seeking, early detection, and treatment of cervical cancer. I went on with 5 specific objectives, which we are going to look at, each one of them at a time. But before that, I would like to introduce to you and discuss with you what you perhaps already know about, which is the model that I've used to underpin this study. And this is referred to as the model of pathways to treatment. Now, the model of pathway to treatment is a newer refinement of the Anderson model, which was referred to as the general model of total patient delay, which portrayed that health-seeking is a linear process, starting with recognition of symptoms and goes step by step until treatment or death. Now, the new model supposes that the whole full process is an iterative process, which starts with identification of abnormal bodily symptoms and progresses, and that there are identifiable events within this. There are intervals that occur, and within these intervals there are processes that can be understood. And when these are understood, they can actually help us to identify the critical steps and barriers in patients' pathways. Now, in this particular study, I have used 2 intervals. I concentrated on the first 2 intervals on this model, which is the appraisal model, the appraisal interval, and the help-seeking interval. Now, the events that are occurring here starts with detection of body changes, abnormal bodily changes, and the person thinks about it, probably manages it, but if they fail, they probably then decide that, oh, maybe I should seek and make consultation with a healthcare professional and makes appointment to do the same. But there are factors. There are factors that can control all these that are going on. And these are the patient factors and healthcare provider factors. I am not going to be dealing with disease-related factors in this particular presentation. So this is what we are going to be looking at a little more. And this study was done in northern Uganda, in Gulu, about 360 kilometers away from here. Ladies and gentlemen, let's look at the first study. I have done 5 studies. We are going to go through them. And in this first study, I explored the perceptions and beliefs about cervical cancer risk factors, symptoms of the disease, the cause of the disease, the treatment, and the challenges to health seeking, as based on a qualitative study with focus group discussions and key informants. And the questions that were used, or the guide, was based on Kleinman's illness explanatory model, which tends to explain how illnesses are perceived and how societies, different societies, develop perceptions about risk factors, symptom, cause of disease, and that is the model that I use. But also I asked the participants of this focus group the challenges that they perceive or that they experience during health seeking. Content analysis was used in getting to the answers to my questions. Now, I included all the people in the study area. These were in 2 villages in Gulu, one in the municipal and one in Achwa, which is a rural place. And all those who professed or were reported by the LC to be Achole and grew up in that region, and they were lay, meaning they do not practice any medicine of any sort, whether traditional or modern medicine. We excluded people who self-reported, who had documented hospital diagnosis of cervical cancer, and also their families, because these persons may have had lots of influences in their knowledge of cervical cancer while they were seeking care. Now, this work has been published in BMC Women Health, but let us look at exactly what is it that we found. We found that the community has got a local name for cervical cancer called tuoremo, or literally translated meaning a disease characterized by genital bleeding or blood disease. And we also found that most participants in the focus group and the informants interview were aware of the known causes and symptoms of cervical cancer. But they also had perceived causes that potentially would undermine appropriate health seeking. For example, some believe that using condom actually causes cervical cancer, and if that becomes a common knowledge, then perhaps people may stop using condom, and yet we know condoms have some purpose in some other fields. The public health specialists perhaps do know that a lot more. Now, we also found that in the majority of the focus group discussions, there are socio-cultural and political situations that influence the understanding of the causes of cervical cancer. For example, here we have one person who says the food that were distributed while people were in internal displaced camps could perhaps explain the reason as to why cervical cancer has, in their observation, become common. Now, regarding the cause of the disease and the treatment, most of the participants in most FGDs believe that cervical cancer is a chronic illness. Cervical cancer can be treated with both the Western medicine and traditional medicine, and that cervical cancer is not curable. Now, the second aspect of study 1 was about the challenges that people face when they go seeking health care. And there were 3 categories of challenges that came up from the focus group discussions and the key informant interviews. One of them is health system factors, which relates to long distances to the health facilities, long waiting time at the health facilities, and we have got examples of what people have said about this. Now, the second category of challenges that came up are the health professionals factors. Participants believe that the healthcare professionals sometimes are repulsive. They exhibit negative attitudes, they demand for bribes, and they sometimes, in their words, steal medicine away from their facilities and take to their private clinics. Why go to them, these thieves? The third and the last category of challenges were the socio-cultural beliefs. Now, this has to do with examples being cancer is incurable with the Western medicine, and their traditional medicines are more superior in the treatment of cervical cancers. They are available, they are cheap. But also there is fear of embarrassment at the health facilities, particularly relating to the age of the participants, but also the manner in which when examination of the pelvis is being done, patients think that particular kind of position is embarrassing to them. This work has been published in the European Journal of Cancer Care. It's openly available and we can look at details. We now move into study 2. In study 2, I extracted concepts from study 1, added onto what I gathered from literature, and then formulated a questionnaire to assess community awareness of cervical cancer risk factors and symptoms, and also their beliefs about prevention and treatment. And this was a population-based survey that involved 448 participants, and the independent variable here was the socio-demographic characteristics of the participants. And the outcome measures were recognition of risk factors. We listed risk factors and we would ask the participants to identify, and logistic regression was the main method of analysis. This has been published in Health Expectation. Again, it has been made publicly available. Now, we'll go through a few of the findings in this population survey. Up to 99% of the people had heard about cervical cancer, and the most common source of information about cervical cancer was the radio and healthcare professionals, but also some people heard from friends and families. Cervical cancer is believed to be preventable. However, there is limited awareness on the method of prevention in the community. They believe that when cervical cancer is diagnosed early, it can be treated. Now, one of the interesting things here in this table, which regards recognition, is that whereas the participants did not mention the name of HPV, the human papilloma virus, they strongly believe that cervical cancer is caused by some virus that is sexually transmitted. Recognition of symptoms of cervical cancer was quite good among the participants, but of importance in terms of early detection, particularly in a place where there is no population-based cervical screening, is the fact that participants do not believe that actually cervical cancer can present with no symptoms. The third table here is showing us perceived causes. what people think causes cervical cancer. So these are concepts that we picked from the focus group discussions and put into the questionnaire. Now, importantly, we find that up to 63% believe that use of contraceptive actually causes cervical cancer. And that is not very nice in terms of birth control. But also there are some beliefs, such as, not washing the genitals after sexual intercourse causes cervical cancer, believed by about 86%. Is important for hygiene purposes if it can be promoted, but should not be confused while being promoted. I now go on to the third study. Now, the third study involved exploration of perception of cervical cancer patients about their symptoms appraisal and their health seeking. And this was a qualitative study involving 18 cervical cancer patients who were symptomatic, and we asked them about their symptom appraisals and their health seeking process. And thematic analysis underpinned by the model that we looked at is what we are going to be looking at here. This has been published, and this is again the model that we looked at. So we concentrated at these two, and the contributing factors being the patient factors and the healthcare factors. So now, health seeking is controlled by what we perceived of ourselves. If we don't perceive ourselves to be at risk of a disease, then perhaps we will not think of that disease. And so we found that there is very low perception about cervical cancer, particularly among the old women who are not sexually active. They didn't think they are at risk of cervical cancer. It is only the patients who are HIV positive, there were 3 of them, who actually perceived themselves to be at risk of cervical cancer and other diseases, such as TB. Now, regarding symptom appraisals, the initial symptoms were attributed to normal bodily changes and use of family planning. And this definitely delayed help seeking by these women. It was only the HIV positive 2 of the 3 who attributed their symptom immediately to a possible cervical cancer, because they were told of complications in HIV while they were diagnosed. Now, the second interval on our model is the help seeking interval. And the help seeking in this group of people were involving lots of lay consultations with husbands, with daughters, and with neighbors. And most of these consultations, the lay consultations, promoted help seeking. And so in summary, we are saying that there were factors that promoted and factors that delayed help seeking. Now, prompt help seeking was frequently promoted or triggered by when the participants perceived symptoms as life-threatening, when symptom burden had increased to a level which was able to interfere with the work routine, and when there was persistence of symptoms in spite of home-based treatment. However, healthcare was not shut promptly when symptoms were perceived as mild, or when symptoms were interpreted as due to normal bodily changes, and all symptoms were attributed to common diseases for which they could have treatment within their homes. We now look at the fourth study. In this fourth study, I carried a cross-sectional study to assess patient and primary healthcare related factors which are associated with advanced stage cervical cancer at diagnosis. And I involved 149 cervical cancer patients diagnosed in one hospital. And importantly here, we looked at a number of independent variables. The socio-demographic characteristics of the patients, the initial attributions, what did they think was their symptom? Did this help them to come early, or did it delay them? The pre-referral diagnosis by the healthcare professionals, the number of visits to the primary healthcare before eventual referral, the reasons for non-prompt health seeking reported by the patients themselves, and total time to diagnosis. And our outcome here was cancer stage at diagnosis. Now, I am going to show for you the most important findings from this particular study. And we are saying here that when we adjusted, for age, marital status, education attainment, and number of biological children, women who had 5 to 9 biological children were significantly less likely to be at advanced stage of cervical cancer at diagnosis. Perhaps these women have been attending antenatal care, visiting hospital with their children, and they understand that it is important to seek health care quite early. Maybe for other reasons. We did not now do a follow-up explanatory study qualitatively. Now, in this table, we are looking at the primary health care factors that might influence stage at diagnosis. Now, here of importance, again, we are looking at what the primary health care doctors or nurses or clinical officers reported to the patients. So for patients who were told that their diagnosis were probably cancer as they were being referred to the hospital where we met them, they were about 13 times more likely to be in advanced stage. Could this perhaps mean that the primary health care professional find difficulty in diagnosing cervical cancer early? Or is it that patients always report much later? Now, the other important thing is that if participants reported that their reasons for non-prompt health seeking was lack of money, they are again about 6 times more likely to be in advanced stage of disease at their diagnosis. These are quite very important concepts that we will discuss a little later. The last studies, ladies and gentlemen, was with the healthcare professionals, not at the primary healthcare services, but at the referral hospital. And these were 2 referral hospitals, and I explored their perceptions about barriers that they think women face when they are seeking care for screening and also for symptoms of cervical cancer. 15 healthcare professionals were involved, and key informant interview was administered with them, and content analysis was used to get the themes and categories that we are going to be discussing quite soon. This has been published in BMC Family Practice, and we are saying mind the gaps in care. These gaps are important, and we need to fill them. Now, what were the perceived barriers or the challenges? What were these gaps? Now, the healthcare professionals came up with 4 categories of barriers that they think would make patients not come to seek care early enough. The first is patients and community-related barriers, and this included perception that there is lack of awareness on cervical cancer and available services among the community members. There is discomfort with exposure of women's genitals, and that women perceive pelvic examination as painful. But also, very importantly, the older women felt that they wouldn't want to go and meet young people and ask them to undress themselves before them. The second category of barriers that the health professional reported was individual healthcare professionals' challenges. The healthcare professionals themselves also felt that their colleagues may be inadequate in making diagnosis of cervical cancer. And this is an interesting quote from a gynecologist who has been a health worker for now 10 years. And that is quite very informative. Now, the third category is the health facility-related barriers. This is similar to what was reported in the community regarding long distances and lack of money for transport, few gynecologists, no pathologists in the region, and no many other things that they reported in the process. Now, the fourth and the last category has to do with policy. So at the policy level, the healthcare professionals said that the lack of specialized cancer treatment services in the upcountry hospitals limits health services. People don't get to understand the benefit of seeking health care because the services are not available, and therefore they seek care late. And lack of vaccination for the human papillomavirus, which is a primary method of controlling cervical cancer. And here, we have a lamentation or a concern that it is taking a little too long for this vaccine to get around the country. So looking at all these put together, looking at awareness, looking at barriers, and looking at the appraisal and the health-seeking process, we are saying that majority of our participants were aware of the risk factors and symptoms of cervical cancer, but also they held perceived causes which are influenced by socio-cultural and life events that may, in one way or another, divert health-seeking from the health facilities. We found recognition of non-risk factors and symptoms of cervical cancer were not as low in the community as the health workers thought, and some perceived causes may adversely affect health seeking, as we have already discussed earlier. And the barriers we have just discussed them and are related to individual and community factors, health professional factors, and the health system factors. Now, a critical barrier that has been, found in many other places is the issue of the gender of the person doing the pelvic examination and the age of the woman who is coming in. This has repeatedly come up, and we see this reflected elsewhere. Bushinje and others here in Mulago found the same place, a number of women refusing. In New Zealand, similar findings came up, and so this is something which is of importance in consideration in terms of policy when we are looking at cervical cancer screening and prevention. Now, use of traditional medicine is quite common, and not just only in the study area, but also worldwide. Particularly in cancers, a lot of cancer patients are using traditional medicine for different reasons. Perhaps because of barriers, but probably also because they think it has worked, it has been used before. Why not now? Now, regarding personal risk, I have said before, most patients had low perceived personal risk for cervical cancer, and they often attributed whatever symptoms they had to some other diseases other than cervical cancer, because they didn't think they had they were at risk for cervical cancer. But this is against the background that non-recognition of seriousness of symptoms, or not perceiving symptoms, or misattributing symptoms, delays help seeking. Ladies and gentlemen, we are saying decision and time to help seeking in this particular study was influenced by relations, the nature of the symptoms that the patient had, availability and the perceived benefits of treatment, and perceived barriers to biomedical care. But also we are saying lay consultations elsewhere has been shown to improve or influence health seeking quite. And in study 4, we were able to come up with the discussion here that the identifiable subpopulation of women who are likely to delay health seeking and are diagnosed with advanced cervical cancer stage. And of these, the older women, women who are not married, those who report lack of money, and those who don't perceive symptoms as due to cancer or a serious disease are likely to report late. And these can be target for intervention. In conclusion, ladies and gentlemen, we are saying that the study community has well-established illness representations for cervical cancer with local names. They are aware of the risk factors. The sources of information in this community were mainly the radio and the healthcare professionals. There are some perceived causes of cervical cancer that can be detrimental to appropriate health seeking. Cervical cancer is believed to be preventable. However, the knowledge about the method of prevention is a little bit limited. Cervical cancer patient might delay health seeking because of low perceived risk to cervical cancer and because of misdistribution of symptoms. And the delay in health seeking could be related to a number of factors, as we have seen before. Traditional medicine, highly used in this particular region because of its efficacy that has been noted over time. But we are saying, ladies and gentlemen, that understanding individual patients and primary health care factors, as we have said in study 4, is quite very important in targeting intervention to those who need it most. And those who need it most, we think the older women, those who are not married, and those other women who report lack of money really need this intervention. It's important to know them. Now, the implications and recommendations that arise from these findings are as follows. Cervical cancer public awareness messages need to use local names so that people understand what we are talking about, should use the appropriate medium of communications, should emphasize the risk groups, risk factors, the symptoms of cervical cancer, and should encourage women to promptly seek care with any abnormal genital bleeding other than interpreting it as something that will go away. 2, interventions to promote prompt health seeking and diagnosis of cancer need to be targeted to the nature of the barriers to care and the subpopulation of women who are at greater risk of delay and advanced stage cervical cancer. 3, health promotion interventions and biomedical services for cervical cancer should be made culturally sensitive, respect the culture of the people that you are introducing the interventions to, and this will promote uptake of such services. Number 4, we have seen that there is delay at the primary healthcare services, and we are saying in-service training is needed for primary healthcare professionals so that they can recognize symptoms of cervical cancer. There should be deliberate policies to establish population-based cervical cancer screening, roll out the HPV vaccination that has been said to have delayed, and we need to develop targeted interventions to women who are not married. And more research is needed to understand why unmarried women are likely to report late. Ladies and gentlemen, the studies are not without limitations. And in this last slide of mine, then, I discussed the limitation. And one of them is the gender and the clinical oncology background of myself, dealing with women. Potentially, this could influence results and interpretations. But I dealt with this by undertaking, by undertaking trainings and by appropriately using methods that would reduce on this. And one of them was to have a research assistant who is a lady. And so women who were interested that they should be interviewed by ladies only, the lady was there. But none of them asked to be interviewed by lady only. Second, transferability and generalization need to take into account the socio-cultural context of the study community. We discussed how some of the factors related to causes are influenced by the context of the study. And then lack of standardized questionnaire to measure awareness in sub-Saharan Africa may undermine validity and comparability of findings from one place to another. And this is a big problem for many studies. And the fourth is the retrospective recall of symptoms by patients. This is common in most studies that involve patients. But also, again, this is how we ask patients. We don't ask them before they have become sick. When they become sick, then we ask them. So it is really the same way we would deal with them. And then the last limitation is the fact that this was a hospital-based study, and so the characteristics of the women who had not reached the hospital, we couldn't be able to know. And so, ladies and gentlemen, now I take this opportunity to acknowledge my supervisors, both here in Makerere, who have been introduced, and Professor Obinga has already come. We have those who are in Cambridge. I acknowledge members of the doctoral committee who are very key in guiding me. My funders, Thrive and Wellcome Trust. My colleagues at the Department of Makerere, Medicine and Pathology Department. My colleagues in Zambia Hospital. My mentors, Dr. Chigonya Edward and Professor Olweny. My family who has been with me as I move this journey. My relatives and friends. But importantly, I will not forget to acknowledge the research participants, for we may have had no data to discuss. Thank you very much.